Time to come in tonight to do this. You have been doing a fantastic job over the last month. I haven't seen any of you in a month, and we are really keen tonight to get as much engagement through technology as we can, and trying to give you some reassurance about PPE. So this is our first webinar session for the Health and Social Care Partnership ever. And obviously technology is challenging, so bear with us. And tonight we've been able to come along to talk to you directly tonight. We've got Dr. Daniel Carter over here, and Dr. Daniel Carter is an expert consultant in public health, Scotland. And next to him, hopefully you can see, we have Alistair. Alistair is a consultant in infectious diseases for the acute medicine sector in the city. So both have agreed to come along and talk to specifically about PPE. I just wanted to thank you for all the effort, and you've gone an extra, I don't know how you would describe this, you've gone so far in supporting our residents, and we know every day is a different day and there's new challenges, but we will do our utmost to support you, albeit from a distance at the moment. But be assured, we are very aware of the challenges that we face and may face in the days ahead. So I'm going to pass to our doctors, and they're going to go through, you agreed a range of questions, hopefully you can see, from each of the care homes earlier today, and we pass them across, and they're going to take us through those questions and answer as best we can your concerns, anxieties and fears about the use of PPE. So please bear with us, okay? Over to you, gentlemen.
Good, thank you very much indeed all for coming, and to Francis and everyone for organising this event. Firstly, again, just to echo what's just been said, which is to recognise all the really incredibly important work that you do at any time, but especially in the current circumstances, and the fact that there is very wide awareness of the stresses that that's placing you under, and of the concerns that you have, and of the questions that you have about it. So we're hoping through this session to be able to respond to at least some of that. I don't think we'll be able to get through all of the questions, and won't be able to do full justice to everything that's on your minds, but really just to respond to the fact that you've asked some really good questions, and that we're very keen to do our best to respond to as much of that as we can. And this isn't just a one-off thing, it's part of an ongoing process of ensuring that we have all the information we need about the current situation and the implications for you and for the work that you're doing.
So I'm Alistair McConaughey. I'm an infectious diseases physician. So for a living, I look after patients who have communicable disease, okay? And therefore, I use PPE on a daily basis. And what I've learned over time is that the PPE that we use must be proportionate to the risk of us actually catching whatever it is the patient has. And there's a number of reasons for that. One is the more PPE we put on, the less we can do with our patients when we're looking after them, which defeats the purpose. So I could put on my full Ebola kit to look after people with COVID, feel really safe, probably not actually be safe, but I wouldn't actually be able to do anything with the patient. So that's important. The second thing is, the more complicated we make personal protective equipment, the more we increase our risk of catching something. And the reason for that is, when you are wearing PPE to look after a patient who has communicable disease, your major risk is not when you're in working with the patient, your risk is when you have to take it off. And therefore, the more stuff you have to take off, then the increased risk there is of you catching something. And that is particularly important when it comes to taking off stuff that's on your face. So that's the intro to the discussion about visors. So this virus is spread in large droplets. And what that means is that when the person coughs or sneezes, big lumps of fluid come out that contain virus. and that will spray in front of them, it will drop to the floor, it will drop onto hard surfaces. And that's very different from what we call aerosol, which is where you imagine a kind of cloud of stuff around about the patient. That is not, absolutely not, what we see with COVID unless we start doing stuff to patients in hospital to make them aerosolise. So we're dealing with droplet spread. So the way we can protect ourselves is by wearing an apron, a plastic apron. Yes, these plastic aprons are the same as what I wear every single day to look after patients with COVID. A pair of gloves and washing our hands, because we're probably going to pick it up off a hard surface and touch our eyes, nose and mouth and catch it. The face mask is important when someone's coughing or potentially coughing these things up into the kind of immediate surroundings. And because they're large droplets, they drop. And that's where that 2 metre advice comes from. In fact, the 2 metres has a huge safety margin in it. The reality is it's probably about 1 metre, but we say 2 metres to increase that safety margin. So we have to remember that. The visors are another bit of kit that you have to put on, which you have to then take off. And by taking off, you're touching your face. So you need to be sure that you actually need those visors. So I don't wear a visor when I see people with COVID, unless I'm going to be doing throat swabs and nose swabs on them when I'm close up to their face. Now there will be situations where you folk are in that position. Providing personal care, for example, I assume involves that. In which case eye protection probably is a good idea in case someone coughs in your face. But what you're protecting against is someone actually coughing in your face. And my concern, when I hear a lot of noise about eye protection, is that they're actually potentially increasing people's risk because they have to take it off, and it's taking it off that is important. And also people who believe themselves to be really well protected and have high level PPE, the risk is that you lose situational awareness when you're actually in with the patient. And we've seen that on lots of stuff that's been on the news. So I think they have to be sensible, they have to be proportionate, they have to be rational about PPE. So the question was, when should staff wear a visor and mask? I think in terms of visor, it's when there's a risk that someone might cough in your face. I'll let you decide what sort of situations about that. And then Daniel, very eloquently before, described when you wear a mask and when you don't, according to the guidelines. And I'll let him do that because I don't think you heard that. But hopefully what I've said will put what Daniel was about to say into context.
Thanks, Alistair. So just building on that, the forms of PPE that should be used in every situation are the basic ones. And in fact, one of them doesn't even involve any equipment at all, and that's hand washing. For the reasons that Alistair's just described, having clean hands is the most fundamentally important thing to prevent transmission of COVID-19 and indeed many other illnesses, as you're well aware. So that's the foundation, and then on top of that, there's the use of gloves and the aprons, which, as Alistair's also said, are exactly the same as the ones that are used in a hospital setting, and they provide additional protection used correctly to prevent the contact transmission that he's just described. So the mask and the visors come in situations where, on top of the risk of contact transmission, there is that additional risk of direct droplet transmission straight from the face of the patient straight to the face of the healthcare giver. And in those situations, it's about the right balance between the risk and the benefit. And the ways in which you can be safest is not just by adding more and more PPE, but by making sure that you're using the right PPE to manage the specific risks that you're faced with in that situation. So the guidance advises that a mask should be used whenever you're providing care, direct patient care, for someone who is a possible or a confirmed case of COVID-19, or indeed if there are other people in the care home that are COVID-19 cases, because that really increases the likelihood then that there's others who are infected and will shortly be demonstrating symptoms. And then the other circumstance is if there is someone who isn't a case in their own right, but who is being shielded. But that is more to protect them, in fact, than it is to protect you, because they're asymptomatic, they're not presenting a risk to you. It's just an added precaution to protect people who are extremely vulnerable to the infection. So those are the main situations in which they should be used, and in all other situations they can be used. A mask and eye protection can be used. There's no rule that you shouldn't use them, that you mustn't use them, but you do need to do that risk assessment in order to make sure that you're using them in a way that genuinely reduces the risk for you rather than creating additional risks. And as I said earlier, the HSCPs have developed a tool which is due to be shared out to staff to help you to make those risk assessments where they are called for. There were a couple of good questions about what to use in the way of PPE if you're going to and from work car sharing with colleagues, and another related question about staff who may be working together, not with patients, but staff working together in a confined space, such as in a kitchen area where they may not be able to maintain the 2 metre distancing. I think to go back in a way to what was just said there, the main things that should be used in all situations are to use social distancing as much as you can, but it's not like it's a brittle rule that if you can't socially distance, then you're suddenly at a massive risk of infection. No, it's something that across the whole population we should do it as much as we possibly can, but there is some flexibility, recognising that certain people are in situations where they have to work and it's not physically possible to maintain that social distance. And in those cases, there's a degree of flexibility around it. But where there is that flexibility, then that puts even greater emphasis on the other things that can be done to prevent transmission risk. And again, the first of those is, if you are symptomatic, don't come to work. That's the first most important thing. So the people yourselves and the people you're working with, and potentially sharing a car with or a kitchen space with, they should be well. If they're symptomatic, then they should leave that area and they should actually go straight home and self-isolate at home. And then the second measure is hand washing. So if you're washing your hands regularly, that reduces the risk of contamination, not through a direct droplet spray, but through contact with surface areas that could be contaminated. The situations in which we do a test is where a doctor wants to know specifically, is this person positive for COVID, in order to guide the treatment for that patient. And that is something that really kicks in if their patient has become so unwell that they need to be in hospital, as Alistair's just been describing. And beyond that, there are actually relatively few situations where doing the test really gives you some extra information that makes a genuine difference in what happens next to that person. One of the exceptions, though, is where someone like you and me, a healthcare worker or a social care worker, is stuck at home, not because they themselves are unwell, they're completely asymptomatic, they could be at work, but because they're having to self-isolate because one of their household members is unwell. Now, if we can test not the healthcare worker, but their household member, whilst they're symptomatic, and if that test comes back negative, then that gives us a good degree of confidence that that symptomatic household member's symptoms are caused by something other than COVID-19. And therefore it allows the healthcare worker to return to work. So that is one situation in which testing is being done, and there is a system open to all of you, whereas if you find that you're stuck at home self-isolating because one of your household members is symptomatic, tell your line manager, because they can log a request for your household member to then get tested. Increasingly now we're moving towards testing of healthcare workers themselves, and you are eligible for that as other health and social care workers are. And the mechanism for accessing that is exactly the same one. But if you come back positive, we don't then automatically test all your household members
We've
on
been
the
doing that
back
when
of
people
that.
have said they're unwell, they've been going for testing. There are some challenges about that if people don't have their own vehicle, but we are working.
That's an issue that's being looked at. But if one of you is symptomatic and you request a test and you are tested, and if it comes back positive, we won't then go on and test all your household members under the current arrangements. That's not what happens. Household members get tested only when a healthcare worker is asymptomatic and stuck at home because their household members are symptomatic. And again, I just want to reiterate everything that Alice has just said about how, in actual fact, the information that a test gives one is much less than is often perceived to be the case. If it turns out positive, all that tells you is it confirms something that was already suspected and which should already have been acted upon, which is that that person previously may have been a case. Well, now it's known that they actually definitely are. But already all of the implications of that are already in place around PPE and self-isolation, or isolating that person in the side room. And if it comes back negative, then there are all sorts of reasons why that test may have come back negative, and it's often quite a complicated story around, does that really mean they don't have COVID-19 or never had it? It's very limited in what it can tell you in that sense, and it's only useful in a very certain set of circumstances.
So this is a clinical question, and it's probably no different from the decisions that you face every day with any patient or any of your residents who become unwell, and whether moving them to hospital is appropriate or not. i.e., is anything to be gained for that person by moving them to hospital? Is it in their best interest to be looked after in hospital? And that's the question. So if you have COVID-19 and you have a lot of medical problems, then you have a very high mortality from that illness. There's not a lot that I do in hospital for patients when they come in, other than to give them oxygen and support them to the point where they start to recover. That's what we're doing. So the ultimate bit of that is whether they're going to be put on a ventilator. And again, ventilators don't treat COVID. All a ventilator does is it takes over the work of breathing for someone to give them a chance to recover. But whilst you're lying paralysed in a bed in intensive care on a ventilator, you're not moving, you're not using the muscles that make you breathe, and therefore every single day that you're in intensive care, you are getting weaker and weaker. And at some point, someone's going to want to switch that ventilator off, and you have to have the strength to take over that work of breathing yourself. The average length of time that people are on ventilators with COVID is over 2 weeks. So we know that particularly older people, just when they come into hospital, lose 1% of their muscle for every day that they're in hospital, even when they're not on a ventilator. So if you've got someone who can't walk very far without getting exhausted, they're not going to have the physical reserve to survive being on a ventilator. And we are likely to say, we don't think that ventilation is in this patient's best interest, it's not going to change the outcome. It might be if they come in and they've got secondary bacterial infection, we can give them some antibiotics, we can give them some oxygen. But I guess what I'm getting at is, what does moving the person to hospital add to their care? There's a question about how to remove PPE, and given what I said about the risk being when you actually take your PPE off, I thought I might demonstrate it, if that's okay. At least I'll show you what we do in terms of taking off our PPE. I need to put it on first. Just to add what Daniel's just said about the questions about being in a car, I think it's an excellent question. I think the reality is that we're probably most at risk from our colleagues rather than our patients. The first thing is, if you've got symptoms, don't go to work. But if you're sitting in a car side by side, you're not face to face, then you're not going to contaminate someone directly into the face, so a face mask is probably less use. Whereas washing your hands or using alcohol gel when you get into and out of the car is a far more sensible thing to do, because you're going to pick it up from the hard surfaces in the car. And I guess it's the same when you're working in the kitchen. You try to keep your 2 metres distance. And if you've got symptoms, you don't come to work. And equally, you try not to have that face-to-face interaction. One of the questions was about these things billowing out at the side. They don't if you put them on right. So you put it on, mould it to your nose and tuck it under your chin, and then it won't. But it's droplet spread, so it's fine. When I look after people on the ward, this is what I wear, okay? As Daniel said, I don't wear full gowns, I don't wear respirator masks, I don't wear, I was going to say a hairnet, but I haven't got any hair anyway, so it would be pointless. I don't wear shoe protection. This is what I wear, and I've been looking after patients with COVID for 2 months now. And I've not caught it. So, you know, this stuff works. So, nobody is shooting film of the general wards where we're looking after the vast majority of patients. All the filming is done in intensive care where they're generating aerosols, as Daniel described. So that's the PPE that a lot of people are seeing, but this is the reality. So you're getting the same as we are. So when you take this off, what you have to do is consider your most contaminated things come off first, and that's your gloves. So what we tend to do is alcohol gel the gloves first. Let that dry. You have to go a bit like this. It looks like everybody's farted, but it's okay. Get the alcohol gel off, and then you take your gloves off. And the gloves come off without touching your skin. So you take it off, you can actually just take it off straight inside out, and then finger underneath to take the other one off, and you're holding them on the inside, and then they go down. More alcohol gel in your hands, just in case you may have picked something up in your hands. Let it dry. It's the drying that kills the virus. So give it a minute, let it dry. Then take your apron off. And if your apron's going to be contaminated, it will be the front of your apron. So you're trying not to touch that. So what we tend to do is undo it at the top first and let it fall forward, and then take it off at the back and fold it inside out. So I can touch that, that's the inside. It's fine, I'm turning it inside out. It's going in the bin. But in the off chance I might have contaminated my hands, I'm going to put more alcohol gel on. And I'm going to rub that in, and I'm going to give that a chance to evaporate. Now, if I had eye protection on, which I don't wear routinely unless I'm doing nose and throat swabs, the next thing I would take off would be the eye protection. And you have to be careful that you're touching the side of it, not touching your face, and you're taking it away from you, because that's the contaminated side, and it goes away. More alcohol gel in your hands. Now what we're doing is keeping the mask on for the full duration of the kind of clinical session. So if I'm doing a ward round, which can last 2-3 hours depending on how slow I'm feeling that day, I will keep the same mask on for that full ward round. Unless the mask is obviously soiled. So unless someone's coughed in me on my face or something like that, or I've kind of coughed in the inside of it, I guess. But unless the mask is soiled, I would keep that on for the full ward round. And then when you take the mask off, you're taking it off and away from you, because it's the outside which is contaminated. More alcohol gel, go and wash your hands with soap and water. And that's how we take off the PPE. So you can see by having two things in your face, I'm actually touching my face twice. So I'm potentially increasing my risk. So that's the balance of your risk assessment for eye protection. So the first thing to say about this, it's a virus that has an envelope, and what that means is that soap and alcohol, stuff that dries it out, normal detergents will actually kill the virus. So sticking your clothes in a washing machine, washing them at the highest temperature that the fabric will allow, and using washing powder, and if you want to be extra careful, either tumble drying it or ironing it, is sufficient to kill the virus. The advantage of having a uniform is that you've got a single thing that you can then go home and launder on its own. So that's the advantage of a uniform. So I don't have a uniform, I don't wear a uniform. We've been given surgical scrubs, but there's nothing magical about surgical scrubs that makes them particularly kind of immune to viruses. It just means that I can go home and wash my clothes on a daily basis so that I don't contaminate my wife's clothes with anything that I might have picked up at work. But it's less important than washing your hands and being careful about what you do with your hands.
And what about shoe covers? There's a question about shoe covers.
So I don't wear shoe covers. I don't think they add enough to make it justifiable in terms of taking off. So when I've taken that PPE off, if I also have to take shoe covers off, that's something else I'm touching to contaminate myself. And unless someone actually coughs on my shoes, it's not really a risk. So it's overkill. I don't wear shoe covers. So I think it's just more stuff to take off. The more complicated you make it, the increase in your risk.
The staff have raised concerns about their arms not being covered.
I deliberately took the top off because we have bare arms as well when we're looking after patients, and occasionally a patient will reach out and touch you, but you know what I do? I wash it afterwards. Soap and water or alcohol gel, and I wash it. It's where I talk about situational awareness. When you go in and I know that someone's touched me there, so I'm not going to touch that. And when I'm taking my PPE off, I'll probably put some alcohol gel on it, and then when I wash my hands, I'll wash it, because that's going to get rid of it. And I've done that. I've been looking after someone with Ebola when I've had them vomit up on bare skin on me, and you just wash it with soap and water. It's got to be proportionate, it's got to be rational. But I get that it's scary, I get that. But we just need to keep our wits about us.
There's a couple of questions about wearing masks all day.
So you have to remember that mask is potentially contaminated. So I wear that when I'm in one clinical area. So I do a ward round, and if I leave the ward, I take that mask off, it goes in the bin, and I wash my hands. What I'm not doing is wandering about the hospital with a mask hanging down here or keeping it on my face, because it's potentially contaminated. So I bin it and I go and get another mask.
There's a linked question, if you don't mind. So how long does the moisture resistant mask work for?
So I don't know is the answer, but the fact is that for a droplet to get through that, it would have to come straight onto it and go through. These are fluid repellent masks. So unless it's obviously soiled, or unless you think someone's coughed in your face, in which case you should take it off and put a new one on, I think it's fine. I use the same mask for 2-3 hour ward round.
There's a question about the goggles. At what circumstances would you recommend actually wearing the goggles?
So I think you should wear goggles when you're up close in someone's face. So as I say, I wear goggles when I'm doing throat swabs and nasal swabs, because the swabs that we do to test for this go right to the back of the throat. It makes people gag. They go right to the back of your nose, and it makes people gag as well. It's horrible. And therefore I'll wear goggles when I do that, because I'm in their face. But on a ward round, when I'm just seeing people, I don't wear eye protection. If someone is coughing a lot in their room, I'll ask them to wear a mask. I'll put it on the patient if the patient can tolerate it, because that is a really effective way of stopping any environmental contamination. So I guess for you guys, it's when you're in someone's face, so cleaning someone's teeth, providing personal care that puts you in a very close proximity to their face, and particularly if someone's coughing.
So many of you will have seen pictures in the media and elsewhere of healthcare workers wearing a different type of mask, which is an FFP3 mask. And it might be worth, just from what Alice has just said there, explaining the differences and how those relate to transmission risk. So as we were saying earlier, COVID-19 is transmitted through contact. If you touch a surface, then touch your face or your eyes or your mouth. Or if respiratory droplets, and they're microscopic or small droplets, but relatively speaking, they're quite large. You know, the droplets that someone might produce if they cough or sneeze, they don't float around in the air, they just drop out of the air and land on surfaces. And those are prevented through the use of the mask, and in some situations a visor. There are some things that can turn those droplets from being relatively large items into much smaller ones. It can vaporize them so that they become what's called an aerosol. And those aerosols can behave quite differently. So they can remain suspended in the air for a period of time and can potentially move longer distances through the air as a result. And they therefore require a different type of mask to filter those types of much smaller particles out. However, those particles are only generated in situations where very specific things are being done to patients. When procedures such as intubating them are being done, or the patient's being ventilated, they're not the sorts of things which would normally be done in a care home environment. If ever you are doing those procedures, aerosol generating procedures, in a care home environment, then you would need to have access to that form of PPE and the training that goes along with it. But that is absolutely the exception rather than the rule. And the PPE that is relevant to your work isn't the one that applies to aerosol particles, because they don't exist in that environment. They only exist when those specific procedures are being performed. So the fact that you're seeing pictures in the media and elsewhere of those additional levels of masks and not seeing those in your own work, it's not because you ought to have them but you don't. It's because they're being used for a very different set of risks and procedures that are being performed on patients than the ones that exist in the setting that you're working on.
No, it's plastic. It's waterproof. So unless I'm doing something that's at risk of tearing it, in which case I just need to be aware of that. But no, I'm not worried. It's no thinner than what we're using in hospital.
They've been designed to be thin, so that they're lightweight to wear, and so that hundreds of them can be delivered in a single carton. It's actually a design feature of them, rather than them being substandard in any way. When it comes to PPE, so let's be clear about what we mean by a non-COVID versus a non-COVID patient. So any patient who has the relevant symptoms is in effect a COVID patient. As soon as someone has the symptoms of a persistent cough or of a fever that's new in onset, then they should be approached as a COVID patient, because they quite likely, in fact, are a COVID patient. They've got the relevant symptoms. And at that point, they're considered a possible COVID case or patient. You then can have COVID patients who are a confirmed case. And all that means is that they've been tested and the test result has come back positive. But in terms of how you need to interact with that patient and approach that patient, it makes no difference whatsoever. The level of PPE and the precautions that you should use aren't held back until you get a positive test result. They start straight away once that patient has symptoms and has been identified as having the relevant symptoms. So by the time they might get tested, if they do get tested, because there's not always a benefit to testing them, in fact, if they were tested, by the time that test comes back positive, already the things that are needed to prevent cross-infection are already in place and are underway. And so I think in that sense also, from a kind of clinical standpoint, I'll leave Alistair to talk about it, but COVID patients are generally managed in the same way. So if they are unwell enough that they need to be transferred into hospital, then they would be transferred into hospital. If a decision about end of life has been made and it's been deemed that that's not the appropriate thing for that patient, then that applies whether they have COVID-19 or not. But Alistair can talk a bit more about that side of things.
Yep, I mean we're just looking after these people in single rooms. That's what we're doing. They're not special rooms, they're just single rooms. We've not got any fancy airflow or anything like that. And it comes back to what I said about PPE and being aware that the more PPE you put on, the more challenging it is to provide care to the patient. And we need to balance our PPE accordingly. So exactly as Daniel said.
So if someone is off work because they've been symptomatic and self-isolating, then one of the conditions indeed is for them to have been free of any fever for at least 2 days by the time they come back to work. So maybe to give a bit more detail around that, the moment anyone becomes symptomatic, they should go straight home and self-isolate at home. And that applies to all of you, it applies to me, it applies to Alistair, and it applies to actually anyone, regardless of what work they're doing. If you become symptomatic, you should self-isolate. And that self-isolation should last for a minimum of 7 days. On the 8th day, you can then discontinue that self-isolation and indeed return to work, provided your symptoms are improving and provided you've not had a fever for the last couple of days. If those are both met, then you can return to work. I don't think it's necessary to formally screen people for a fever, because it's for the staff member, and staff members are trusted in that regard. If the staff member knows that they've no longer had a fever, I don't think it adds anything else to have a temperature check at the doorway.
So do you want me to talk? So there's a lot of discussion in the media about testing. Let's be clear what a test is. A test that we have at the minute. Tests for the presence of the virus in the back of someone's throat and up their nose. So the test is extremely sensitive if the swab is done correctly, and that test will tell you if there's virus present at the time when you do the swab. And that test will pick up live virus, and it will also be positive when someone has dead virus up their nose. So we know it's 7 days. Even when a patient's better, you might still be able to detect virus at the back of their throat. That does not necessarily mean that they're infectious, because it's likely that the vast majority of that virus is actually dead. And that's an issue we have with the test at the minute. What in some ways is the Holy Grail is an antibody test, and that antibody test is an old test that we use for infection, And that would tell us if at some point that person has had COVID. And those tests don't exist with any reliability at the minute. Technically, it's really difficult because coronavirus has caused the cold every year. And most of us have had a cold over the last few months, and therefore will have falsely positive tests, i.e. will have antibodies against coronaviruses. And that is the test that will tell us if someone's had it. So I think there is a limitation to what tests actually tell us just now, but that's a limitation of the technology as opposed to anything else. And it makes them useful for diagnosing people who have symptoms, but does not make them particularly useful to tell us when someone's no longer infectious or if someone might have had it in the past.
Is there anything you gentlemen would want to add that we haven't thought of in these questions?
Not really. Does anybody have any questions about any of the answers we've given? Does anybody want...
Anybody? Shirley, does your team have any questions?
Or comments on what further information might be helpful to you, even if we can't provide it now?
One of the questions that Charles had talked on, I was thinking about the hand gel. So that test we haven't been using will be taken off as well. So it's not part of the Scotland guidance today. So that will be something that will be started with.
So using the hand gel and the gloves?
It's not in the guidance as a requirement to provide it. We do provide it, it is available, but we haven't been using it with the gloves. I've never seen that done before either. So it's a fair point.
So that's what I've demonstrated. So that's what we've always used when we're doffing. So can you hear me?
Can you hear us, Shirley? Yeah.
Yeah. So what I've shown you there is what we've always done when we are doffing after looking after patients with communicable disease, where we've got gloves and aprons on. It's what we always do, and that's what we do, and it's probably overkill in terms of this, but I think it's a perfectly reasonable thing. I think being very careful about that, I think that's a lot more use to you than wearing eye protection, for example, when you don't need it. So I think putting alcohol on the gloves and letting that dry is just a very safe way of doing it. But you're right, it's not the guidance.
Linda, does your team have any questions at Victoria Gardens? Victoria Gardens, any questions? Okay, because we have got all of your questions. I see Meadowburn's just returned. Anne, can you hear us? Anne, did your team have any further questions?
Have you got any further questions? Yeah.
Yeah, so this. Yeah, no, I get that. So this is really difficult. So we've got patients in hospital who wander as well. I think it's a real challenge. I think we just have to do what we always do in terms of trying to coax them back into their rooms. I think probably the important thing is gloves and aprons when we're doing that, and we wash our hands afterwards. If that person is coughing, I would try and get them to wear a mask if they'll do it, which is a variable kind of comfort for people. But I think you just have to manage it as best, but I totally accept it's a real challenge.
I think that's one of many examples of where your experience and your expertise is massively important and massively valuable. That's a conundrum that you're used to facing, and all of these guidelines about social distancing and isolation are written in a kind of perfect world, but it's, I think, recognised that they can't always be implemented to the perfect standard in every situation because of those real world realities. And so what you can offer is to do the best that you can to maintain infection control, and to do that in a way that's safe for yourself through the PPE, but also as safe as it can be for the individual who's wandering and the other residents in the care home. But no one can expect that that is done absolutely perfectly in every situation, because that would require the door to be locked, and that comes at all sorts of other disadvantages. It's not acceptable. So really, your own expertise is something that's hugely valuable and important around all of that.
Okay, any other questions from anybody? No? No? Okay, I'm going to thank you guys, because I do appreciate you've just started a shift, and again, appreciate all the effort and good work that's going on, and we hope that we will continue these sessions. We'll get better, I'm sure.
Can we feed up if they've got more questions?
Yeah, if you've got more questions, Daniel's saying we'll feed them through for tomorrow's session as well. We've got a call first thing, so we will do that. There's another session tomorrow at 2. And I'm going to let you go and look after your residents, and thank Daniel and Alistair on our behalf for giving us their time tonight. Thanks everybody, have a good evening.